Top Med Talk.
Well, hello and welcome to Top Med Talk. I'm Desiree, Chappell, Managing Editor of Top Med Talk, and I'm joined by my co-host, Professor Monty Mythen. Hello, Professor.
Hi, Desiree. Hi, Desiree.
I know I don't usually refer to you that, but we've been here at EBPOM Ireland and EBPOM Chicago. How's it going, Monty?
It's great. It's great to be back in the room with people and having, actual real live conversations. I mean, we've done a huge amount online and, nothing to say anything other than great things about what we've managed to achieve with the various different online tools. But it's just something you can't quite, get that final bit without getting people back in a room.
Yeah.
So it's good to be here.
It is good to be here. There are some of us in person, which is great. And we're back at it. So kind of back to where we started with Top Med Talk, going to meetings, talking to people, that we meet, talking to people about things that we discuss during the meeting, which today it's kind of like that, isn't it, Monty?
Absolutely. I mean, part of when we started this Top Med Talk journey, it was in anticipation of the world being very different. We wanted to reduce carbon footprint. We wanted to extend the reach. And then people will say, well, you're still doing quite a lot of traveling around. But if you look at the number of flights you've taken out by using this methodology, it's a huge contribution and the reach you have. So, still traveling around, getting back in the room with people, but we're never going back to exactly where we were before.
No, definitely not. Today, Monty, we are wanting to thank our sponsors, first of all, for helping, to make all of this happen, because it does take a lot. And so we wanted to thank Acacia today for sponsoring our podcast and supporting all the efforts that we really do through Top Med Talk and EBPOM as well. And so we really wanted to continue some conversation that we were having yesterday during EBPOM Ireland, or a couple of days ago now, about novel therapies and treatments of conditions and things like that really require kind of new ideas and new therapies.
We reached out to Acacia because we'd been hearing in interviews about a few novel therapies. And one of them we heard about was via interviewing TJ Gann, you'll remember, at the European Society of Anesthesiology in Vienna. Gosh, it must be about 2 years ago now.
Yeah, 2019.
And TG was telling us about new guidelines for PONV, but also spoke, and you can listen to the podcast on Top Med Talk, about a novel antiemetic agent. And as we've referred to in this series we're recording, that was a real yawn moment. Oh, really? Until he explained that actually, if you think about the wonderful antiemetics we use at the moment and how much we've reduced post-operative PONV, it's almost entirely prophylaxis. And once we have used our prophylactic agents, we reach a buffer for the patient who's still nauseated in particular. We don't have that rescue therapy. Yeah. So we started to learn about Amisulpride, which I knew in Europe. I work in intensive care, and there's for occasionally, you see overdoses, for example, or patients with particular conditions. I knew it as an anti-schizophrenia agent. But as we learn the journey of it, Amisulpride had every reason why it should work as an antiemetic because of its receptor profile. And as we've been learning in this series, very clever redeployment at much lower dose of Amisulpride has brought to us an agent that is now approved not only for prophylaxis, to add to that box we have of prophylactic interventions, but also for treatment. So when we're on the floor, seeing those patients post-operatively, as I said, I see them on the surgical high care area. When you've got that patient who's grey and holding a vomit bowl, which happens no matter how hard we try on day 2, 3, we've got something to offer them now. That's what we're going to talk about more today.
Yeah, so we've dug into kind of the pharmacology and some of the other specifics about it. Today, we really want to talk about what does it look like in practice? How do we as clinicians use this? And joining us today, we're going to speak about this, is Drew Riddle. He's an associate professor of professional practice and director of clinical education at Texas Christian University School of Nurse Anesthesia in Fort Worth, Texas. He's a CRNA. Drew, thank you so much for joining us.
Well, thanks. I appreciate the invitation to be here. It's great to be with you both again.
That's right. Well, actually, Drew, you're kind of a fan fave on Top Med Talk, because this is not the first time that you've been here, and very popular, and people have loved some of the conversations that we've had on Top Med Talk. But Drew, for people who may have not have heard the conversations we had before, give us just a little bit more about yourself.
Sure. Yeah, as you said, Desiree, I'm faculty, a professor of anesthesiology at Texas Christian University. I am a practicing CRNA here in the United States. So I've been in clinical practice a little over 20 years, maintain an active practice, sort of in I guess, a community hospital of a little bit of everything. We do sort of all comers, but we're not necessarily specializing in one particular area or one particular area of expertise. My research interest for the last probably decade or so has been specifically in pharmacogenetics. And one of the areas that we focused on is the genetics of nausea and vomiting, and specifically that disease state that perhaps is a bit different than what I would call normal nausea and vomiting, and that is the nausea and vomiting that's postoperative, whether it's anesthesia drug induced or surgical stress response induced. I think there's probably a combination there that we don't yet fully understand and haven't wrapped our heads around, which is where my interest lies in, as you said, Monty, a bit of a topic that becomes, a bit yawn, like, oh gosh, I've been doing anesthesia 20 years. If I hear another person speaking about nausea and vomiting, I myself would likely have nausea and vomiting listening to that. But the reality is we're not there yet. We don't have the magic treatment, the one drug or intervention that prevents it or treats it in 100% of our patients. So yeah, a little bit more about my background. I also have the honor of co-chairing the Cochrane US network, the Cochrane Collaboration and International Evidence-Based Medicine, Evidence-Based Practice Organization. And we've re-envisioned what Cochrane looks like in the US. I work with colleagues all across the US in evidence-based practice, which has really stretched me a bit because my very singularly focused world has been perioperative medicine for years. And now it's making me really get out of my bubble, which has been humbling and also very interesting to see some of the other, I didn't know if anyone else knew, but there's other problems in healthcare besides just anesthesia. Who knew? But I've learned a lot about it. It's been great.
Andrew, if I could touch for a second as a Cochrane collaborator myself, having done a number of Cochrane systematic reviews, the methodology is very, very demanding to keep you strictly within the guardrails of how you set out your question and what the evidence provides to you. So the subjectiveness in reviews is very much beaten out of you. It's kind of,
that's a really good way to put it. I think beaten out of you is a very strong way. Having myself publish multiple reviews, I know this isn't a talk about Cochrane, but I guess can't not put a plug in that, Cochrane evidence is robust, it is rigorous, and it is to the extent possible unbiased. And so it really does help culminate together all of the evidence around a particular topic or question in as unbiased a way as possible. There's always going to be biases in health related research, of course, but to the extent possible, I think you're right. It really, the rigor and the methodology really causes it to be as true as possible, I suppose, is a good way to phrase it.
So the series that we're doing on Amisulpride, I want to talk to you about it from the lens of, a provider, a clinician on the ground utilizing it.
Sure.
And so I guess the first question, though, that I have for you is, do you think, and this is probably, obviously biased, but do you think that clinicians, anesthesia providers, CRNAs, anesthesiologists really understand that there is still a problem with post-op nausea and vomiting?
It's $1 million question. And I think the short answer is no. The longer answer is we have our bias as well in clinical practice. And that bias looks like this to most of us clinically. I do a pretty good job at providing an anesthetic. I do a fairly decent job at stratifying risk, at looking at those factors that contribute to my patient's risk, whether it's for post-op nausea and vomiting or cardiopulmonary events or the like. And in some way to insinuate that I am not doing the very, very best job possible, and my patients have even a tinge, which, as we know, is an official dose or measure of anything, a tinge, a skosh of nausea and vomiting, it kind of comes across as a bit insulting. The reality is we know the data don't lie. And that is, even in high risk patients, those that we do everything possible preoperatively to prevent or prophylax them against having nausea and vomiting postoperatively, anywhere between 20 and 30% of those patients will continue to have PONV. And so the reality is, in the best case scenario, we're getting about 70% efficacy with what we're doing most days, but 3 out of 10 roughly are not getting the best possible outcome. And just looking at some of the data worldwide, and then actually we can drill down, and where I practice in the state of Texas in the U.S., it's the number one reason patients return to hospital post-discharge, especially those patients that are outpatient surgery, whether they've gone to a freestanding surgical facility or come to a community hospital or a tertiary care center, but had an outpatient procedure, were sent home, get home. It's not pain. It's not wound dehiscence. It's not bleeding. It's not surgical complications. It's the fact that they have really poorly controlled nausea, vomiting, and then they come back in. And we know what then that looks like. The patients don't like it. Certainly the healthcare system is overwhelmed already with all of the other things we're dealing with in today's environment. And then we have this person who had a laparoscopic cholecystectomy this morning who comes back with nausea and vomiting that's poorly controlled and requires intervention.
And Drew, I think you mentioned earlier about the genetics of nausea and vomiting, because we're not there yet. We might be there in the future about looking at those genetics and genetically profiling people beyond risk rating. I personally get really bad motion sickness. I happen to be an enthusiastic sailor. So I've learned how to manage and mitigate my motion sickness. But once I go over, I'm a complete mess. It hits me really hard. Whereas other people don't understand what you're talking about. They say, it doesn't bother me at all. And I think Desiree,
same.
presume part of that's genes.
It certainly is. Part of it is genes. And some of the work we did, we studied some of the 5-HT3 serotonin receptor genetics, and essentially the morphology, the shape of the serotonin receptor is quite different. It varies across the population. And there's actually a subset of individuals in the world that do not possess the appropriate genetic makeup to have any responsiveness of that serotonin receptor, specifically the 5-HT3, that subset, which is, of course, where all of our sort of mainstay antiemetic drugs like ondansetron and the like work. And so it would make sense. And we've shown that, through the data, that there's a subset of patients in whom ondansetron and sort of the normal therapeutics are either not effective at all or certainly less efficacious than we would see. We would be led to believe by sort of the efficacy data. And it's certainly beyond just the serotonin receptor. Of course, there's more genetics to it. Monty, it's a great point. I don't know in my career or lifetime, but it would be really fascinating to see an entire genetic-based perioperative episode where clinical decisions about all pharmacology, whether it's turning on or not turning on a volatile anesthetic, or a choice of induction agent, or the exposure to or not exposing patients to opioids, and can we really fine tune and get to the outcome that we all hope for, but unfortunately, quite rarely actually meet.
But in the interim, our challenge is on that follow-up ward round. I said, if you work mainly in the operating room, you drop your patient off, they look great, and you may have been very successful in short-term mitigation of post-operative nausea and vomiting. But those of us who do follow-up ward rounds or work as I do in a high-care surgical environment, those patients have had a fantastic job done for them, and yet there's still the person who's grey and not quite right, and you're seeking for something to help them. And I think that's what, you've had experience now of using this compound as a rescue antiemetic. Is that correct?
That absolutely. And really that's where it is in the US context, at least, it is indicated. Amisulpride is indicated both for prevention and for rescue. And in my clinical practice, I can get to close to a 70-ish% efficacy with, reasonably well documented high safety profile, quite frankly, reasonably inexpensive drugs. And so it's that 30% or so of the patients that look exactly like that. And when we think what that looks like clinically, and why, Desiree, to your initial question of do anesthesia providers, do anesthesiologists and CRNAs and the like realize or believe, if you will, that their patients have nausea and vomiting in a very fast turnover in which we've all been. You drop them off, and in the 2.5 minutes of handover from you to the receiving nurse in the postoperative care unit, well, they didn't have nausea or vomiting then, so they must not have it. We know that the data suggest, and we see this as we follow on our patients as they go down the continuum, that it's in that first 2-hour mark that the nausea and vomiting tends to peak. And so while it may not be in the first 2.5 minutes, in that first 2 to 4 hours is when we tend to see it the highest. And then there's another sort of peak beyond that, especially on those patients that go home. Once they're out of the hospital, they're sitting in the car driving. Well, hopefully they're not driving, riding in the car, going down the road. That some of that nausea and vomiting related to motion sickness, to the vestibular system that gets activated, and then we see yet another peak of post-op nausea and vomiting. And so it's happening, and we really, up until today or recently with the release of Amisulpride, we've had no really good evidence-based treatments. And so, comparing that to ERAS and enhanced recovery, and Monty, I know that's been a mainstay of your career for quite some time. We have phenomenal ERAS recommendations, guidelines, protocolized a lot of the care up until we get to the post-op nausea and vomiting piece. And then it's sort of like, as we describe it in Texas, it's like the Wild West. Who's giving what? It's a free-for-all because we don't really have good efficacious drugs. So we just sort of give a little bit of a lot of things and cross our fingers and hope it works.
Well, Drew, I was just curious, I mean, as someone who works in an anesthesia care setting, I mean, I turn them and burn them, right? Do my cases. And usually if there's anything happening afterwards, the anesthesiologist gets called, or there's an order set that someone follows. So to walk us through what's traditionally being given right now as rescue, what do we have in our armament at this time, and why is that not working for us?
Yeah, well, mid 2020, a set of guidelines to which you referred at the onset was published. And I don't know if anyone else remembers 2020. I don't. Most of 2020 was focused on protecting myself and my patients from COVID. And, guidelines, what do you mean? There was other literature published on anything aside from COVID. And so the timing was serendipitous, but TJ Gann and his group really did publish the consensus guidelines that say in the first 6 hours postoperatively, we should not be trying to treat our patients with an antiemetic from the same class that they've already received. And so what it typically looks like, at least in the U.S. context, and my very sort of focused and I'm in a care team model as well, Desiree, and experience something very similar, is typically post-op order sets say things like, if the patient has nausea or vomiting, repeat a dose of, and then it's a fill in the blank, ondansetron, dexamethasone. If that fails, IV promethazine, compazine, haloperidol, and then it gets into just a crazy kinds of things. And you think, well, I've never thought or used that drug at all in my life as an antiemetic. And someone said, well, it worked once, so we'll try it again.
And that's always the crux of the issue. And they start throwing the kitchen sink at it, and just doesn't really get any better. So what are some of the shortcomings that we've had? I know for me as an anesthesia provider, and really as a critical care nurse as well, one of the last drugs I ever want to give is IV promethazine, just for the sedation factor and for some of the other side effects. I just feel like it's not the best choice for my patients. And so, what are your thoughts?
Yeah, you hit the nail on the head. There's none of us that want our patient. We like our patients, but we don't want them there any longer than they have to be there.
Yeah.
Right. So we want them to, the throughput aspect of healthcare, regardless of the system, is critical. And so anything that causes an untoward side effect, and typically when we think of sort of the mainstay of antiemetics, almost everything we give causes sedation, sometimes profoundly sedated. And I say this all the time, having myself also been a critical care nurse, typically worked nights before I went back to CRNA school. 25 milligrams of IV promethazine will get you through a very difficult night shift with a very uncooperative patient. So we were at times exploiting the side effects of the drug, not using it as an antiemetic, but perhaps as a sedative, knowing that that's the side effect. But in the peri-op environment, there's none of us that would say, well, gosh, I really hope my patient stays an extra 4 hours beyond which they should. And nausea and vomiting, every one of us have experienced it, unfortunately. And there is nothing, in my opinion, there is nothing worse than feeling nauseated or actively. It is a fun thing to talk about, vomiting and retching. But
it's a reality for us.
It's a reality, sure. And then coupling that with, I've just had a surgical procedure, something as benign as a little, lipoma removed to, some big laparotomy with drains and tubes, or a thoracotomy with chest tubes. And then on top of that, I'm retching. We know clinically that looks just terrible. And it really affects patient satisfaction. It's sort of the old adage of you can have a very botched surgery, but if the wound is closed pretty and the dressing looks good, it must have been a success. And patients, if we do our job right, don't remember a thing about us except, oh gosh, I threw up after that surgery. Boy, that anesthesia made me sick. Yeah, of course.
Threw up for ages. Andrew, as you were saying, in this day where we're hoping for universal adoption of enhanced recovery principles,
right,
that immediate post-operative drinking, eating, mobilizing, living the dream,
right,
contributes. That trilogy in itself contributes to antiemesis and anti-nausea, because if anything, different to how we thought in the past, getting something into your GI tract actually can help calm things down.
Sure.
But as you say, what you don't see in the pathways, I haven't seen them yet, is what happens when you deviate.
Yeah.
Right.
Because no one's got 100% drink, eat, mobilize rates. No one.
No.
So there's always, someone's dropped off a little bit. And when they do, again, anecdotes, it tends to be things like postural hypotension if they're in a high care environment, and things like nausea that might be related to their postural hypotension. But therefore we're into, how do we get that person back on track?
Yeah.
Right.
Well, it gives us an idea of what the actual issue is too. So, I mean, to know that they're not drinking and eating or moving, it's because they're having post-op nausea and vomiting. Why is that? Is it because of the hypotension? Is it because they can't take the oral narcotics on an empty stomach? And we've been doing that. And so I love the idea of using that to kind of explore a little bit more. And then I think, to the point of using different medications to treat the reason, or, different therapies and treatments for the things that we're doing, we can be more specific on that. Well, Drew, here in kind of the final bit of this, please just walk us through, what does it look like to use this medication for me, I'm always interested in, whenever we're talking about new things that I haven't seen in practice before, it's kind of like, what's your experience? Like, is it the aha moment? Because I know I've come across some medications I use and I'm like, oh my gosh, this is insane. Or, the verdict's still out on it.
Well, I will tell you that it has been an aha moment for me in my practice. And that is, up until this point, we've all sort of stood toe to toe with a patient who is gray and green and various shades between, with the vomit bucket in their hand, looking at you like, please help me. I need something. And a lot of the something we could use was less than efficacious, or I'm going to give you something and you're going to camp out with us now for the next 4 or 5 hours. And what this looks like is it's a 10 milligram dose for rescue. It comes as one little vial. I love it because you don't have to reconstitute it. You don't have to mix it. You don't have to infuse it. You pop off the cap, you draw it up, and you give it IV push. And sometimes before you finished administering the full dose of medication, you can begin to see that relief in your patient's face, that moment of, oh, wow, I feel so much better. And within minutes, typically, if the reason why the patient was not ready to go was because of their nausea, in other words, their pain is well controlled, they're not bleeding, everything else, all the boxes have been checked. Within 5 minutes, they look at you and say, may I please leave? I feel great. Can I go home? And to have an antiemetic that gives us the ability to treat nausea without the sedating side effects. I mean, I've never had a patient after a dose of IV promethazine say, I feel great and can I go home? It's, I feel great, may I have a pillow? right?
Yeah.
So there's a big difference. And it is sort of an aha moment, because up until now, at least in my 20-something years of being in healthcare, I've not really had a great rescue drug that doesn't cause the untoward side effects. So we're seeing in our system the bit that we've adopted, and we've not been users forever and ever. It's only been FDA approved less than a year in the US, or a little over a year, I guess, now in the US. And we were not early adopters, but now that we've seen it and had it, we're shaving 30 to 45 minutes off of every recovery room admission in those patients that had nausea and vomiting. So, that speaks volumes as well. Patients don't want to leave if they're not ready to leave. And we've all tried to force people out the door, right? You really can go, sir. I promise you're going to be okay. And these are folks saying, I feel great. I'm ready to go home.
So Drew, nothing works all the time,
right?
Which I think we're all acknowledging here. So being enthusiastic about when it works. If occasionally it has not worked, how long do you have to wait to go back to the patient for the moment of disappointment? I don't accentuate the negative, but do you check after 15 minutes, and if it hasn't worked after 15, it's not going to work? Or
So, the data is sort of all over the place. And when I say all over the place, it's anecdotal and it's sort of word of mouth. In my experience, if it has not worked, it's not worked within that first 15 to 30 minutes. But what's been interesting in those cases that I would call it didn't work, we didn't get complete resolution of the nausea, but we got the nausea. If we think of there's vomiting and nausea scales, but something as simple as a visual analog scale on a 0 to 10, their nausea was 9 or 10. And I've perhaps been able to reduce it to a tolerable 3 or 4. Okay. And to your point, Monty, maybe that nausea was the reason why that patient was unable to drink, right? Mm-hmm. And so their nausea is better controlled. They get a little something in their gut, and all of a sudden then their nausea becomes either too non-existent or tolerable to the point where I could live with a little of this. I just had a major surgery, and this is certainly reasonable. So we've also seen it without complete resolution, but that bridge to drinking, being able to, nobody wants to get up and walk around if they're nauseated. So we get them mobilizing a little bit earlier.
So that's really helpful as we start to use it. The second question I have is, every drug has a long list of potential side effects. That's universal with drugs, the package insert. And with something that's been around before at a much higher dose as an anti-schizophrenia drug and other uses, there's going to be quite a scary list of things that it could cause, including the inevitable QT lengthening, the risk of torsade de pointes if you end up with an overdose, etc. But we're hearing that this is at such a low dose that although those adverse events will still be cited there, and we should be mindful and watch out from them, have you seen any adverse events yet?
No, in my practice, I've seen 0. Now they're coming, of course, right? To say absolutes in healthcare is a misnomer. There's never 0 or 100%. But you're exactly right. I mean, the dose is orally 1,600 milligrams orally of this drug. We're giving 10. So, minuscule fractions. And so it certainly can cause the QT prolongation, for example. But at doses IV, you need to get to at least 40 milligrams IV. So 4 times the dose we're giving to begin to see even minor changes in that QT interval. So we're giving, 1/4 of the dose that tends to cause it. The side effect that's reported most frequently is apparently it's a little uncomfortable when you give it in the IV. It can burn. I've never seen that. Yep. But, I've told my patients, hey, I'm going to give you something. It may burn a little bit. And at that point, I think they would be willing to take anything, no matter what the side effect is, just to stop their nausea, of course.
Absolutely.
But really beyond that, there aren't any side effects. It's non-sedating. The QT interval, we need to keep an eye on it. If they have congenital prolonged QT, they're taking other medications that would cause QT prolongation. The recommendation in the US is that they remain on an ECG monitor for a bit just to make sure that we don't see those changes. But in my practice, I've not seen that yet.
Great. Thank you. That's really helpful. Really helpful. We're looking forward to getting to use it.
Yeah. We'll probably get to use it before you get to use it once, but
I think we're getting it soon.
Yeah.
It's great.
Going close. All right. Well, Drew, thank you so much for sitting down and chatting with us about this. And we look forward to future conversations about this and all the other, perioperative medicine topics, hot topics coming up. I think we're going to see you soon at the ASA.
Yeah, I'll see you in a couple of weeks.
Great stuff. And Drew, can I add thank you for your Cochrane collaboration work? I know how hard it is. So thank you for putting those hours in. Yeah.
Sure. It's enjoyable work for sure. Labor of love. Thank you both for having me. I appreciate it.
Yeah. All right. And thank you for listening to Top Med Talk. You can always find more information at topmedtalk.com. And we're on all your favorite social media platforms, LinkedIn, Facebook, Twitter. You can find us there having different kinds of conversations. And you can check out EBPOM, or EBPOM Education Hub, at live.ebpom.org and get some more information too. So thanks for listening, and we will talk to you soon. Cheers.
Bye. Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.